Hello all, we're going to go ahead and get started. My name is Laura Hosford. I'm the clinical bioethicist for Peace Health for the Oregon Network. I'm the only ethicist for the Oregon Network. So I cover all of our hospitals as well as all 70 of our outpatient clinics.
And I'm Amber Thorsen. I am a nurse and I manage the palliative care department at Peace Health in Oregon, so inpatient and outpatient. And Laura and I work together very, very regularly in the most complex, emotionally challenging, ethically challenging end-of-life cases in the hospital. And so while not every slide and every moment of this presentation is going to specifically focus on end-of-life, that is the waters within which we swim and really the context for all of this conversation.
And I'm also on the committee for this, and so I made that rookie mistake of talking about something in the committee, and they're like, "Oh, you should talk about that. You should you should do a breakout." And I was like, "Oh, dang it." No, I appreciate the privilege of coming to speak, but what I was talking about was how rapidly things are changing in healthcare right now, and how we're struggling to adapt as caregivers. But also our patients.
And the main thing that we want to share with you beginning this presentation today is how meta this presentation feels for us, because it's about unraveling, and we are each experiencing and have experienced over the last 1.5 to 2 years of our professional and personal lives a great deal of unraveling. That continues in real time.
Yes, I will share that a few months ago, I moved in with my mother and father to provide end-of-life care. And she actually ended up having a rebound and doing really well. And then a few days ago, while my dad took his first trip out of town and left me in charge, she fell and broke her femoral condyle. And I managed to catch her head, prevent a head injury, was about it. And hospitalized where I work, and my dad was texting me right before lunch, and he said, "Laura, I want to dispute her discharge. I don't think she's ready, and I'm really worried that this might impact you professionally, that they know this is your mother and they're going to think I'm a problematic patient." And I said, "Absolutely, Dad. Go ahead and dispute and do what you think you need to take care of Mom." So it's a challenging time, and we did send not the perfect set of slides. We realized that yesterday, so there are 2 spelling errors, or I can't remember, but for other type A's, enjoy finding those.
And by yesterday, she means 9 o'clock last night, just to be totally clear.
Yes. So this is not this is a welcoming you into a conversation, and we're starting out really vulnerable, I think, because that's sort of the core of this presentation is radical vulnerability and recognizing how much we don't know and how we respond in those situations. So a little Peace Health routine here of starting with a sacred moment. If all of being is a mountain, rationality is a tiny robot scanning it on the surface, in the dark, with a flashlight. Healing is listening, like the basilica with its living silence. Listening creates a space for someone to curl into and be held. Listening is the most delicate form of reaching out. It is the simplest and most powerful thing we can do for one another. And the rationality quote really speaks to us, as all the speakers have said. We have tried to reason our way out of these things. There's the culture war or culture divide, or however you want to put it, and that's not working for us. So what else do we have in these situations?
And just to speak more about the unraveling that is happening, it's happening at every level, right? We've talked today about the fact that it's happening at a national level. I think we can agree it's really happening at a global level. It's happening within our industry. And then when we look at end-of-life care, it's also happening to individual patients and families. We don't have a good cultural story about how to experience and process death. And that means that every death is an identity unraveling and a story unraveling, because the American standard is that we are the exception, that each individual will be the exception, that every person is going to be the person who beats cancer, who beats whatever it is. And so that too has to unravel for people to come to terms with end of life. And so this is this, and then as we've talked about today, because of moral injury, each of us in healthcare has been coming undone now for years. To give an example of this, there has been an unprecedented amount of FMLA going on in the people that I know in healthcare, because people are trying to reclaim through these chunks of time some semblance of themselves and their lives. And I think that's a sign of this kind of layer upon layer of unraveling that has taken place and continues to take place.
So our objectives will be to provide an overview of the changing landscape of healthcare, which I gave up updating the slides because it seems like every week there was a new executive order or change, and so I'm trying to keep it more broad because it was almost impossible to keep current. To consider some of the potential repercussions of this changing landscape, specifically on end-of-life care, and offer ways of being in a changing environment that are not fully reliant on outside resources, because I think it's becoming clear that institutions, the community is losing faith in institutions and laws and things that we thought were pretty concrete are being rolled back now. And so how do we operate in those situations? So one way that it's changing is insurance coverage shifts, consolidations, payment costs and coverage for pharmaceuticals, and advancements in life sciences. So I'll talk a little bit about these. The ACA, I'm sure you all know about that. Uninsured individuals declined significantly to nearly half of what was prior to the ACA. A portion, it increased during COVID. We added more people so that they could access primary care. That we're facing the potential expiration of the subsidies for the exchange for folks who are purchasing these. Potential tax cuts are also set to expire on the state level in 2025, so people are facing reduction in state incentives. And there are already states who have begun legislation for possible implementation of new requirements in order to access certain resources, including being employed. So that's already being pursued in different parts of the nation. So predicting the impact to these Medicaid cuts or additional obligations in order to access these, it's really hard to fully grasp how catastrophic rolling back some of these things would be.
And some anecdotal thoughts we want to share here. One is we have noticed within our own practice increasingly problematic access and conversation with the Hispanic population in our area, whether it's that we don't have the interpretive services that we need, we aren't receiving calls back, we're hearing explicit expressions of terror that Hispanic lives will be not valued the same way, that if there is a claim about medically non-beneficial treatment, that is actually an occult claim that their life is less valuable, less meaningful. And then I think we have to think about the amount of people who are likely to access care later, meaning later in a ongoing developing health problem, and then also in higher acuity. So they might come to us with more advanced cancer. They also might come to us with a really extreme heart failure or a really extreme COPD exacerbation where they're already in florid crisis when they show up because of this fear that we are not a safe place to be, and also the financial fears, the fears of ICE. I want to name here in particular when we're thinking about, when we think of insurance, I think we also have to think about documentedness. And I will say there was a huge ripple of crisis through my department when we were notified that ICE now would be allowed into our hospital. And so I think we really have to think about what it is now to be someone who is explicitly targeted or implicitly at very high risk.
I think it's even mundane things that we do, like if you come in for a trauma and the chaplain lists all your family and their phone numbers and how they can be reached and located. different populations might feel different levels of safety with disclosing that, and we don't have the data on it. It's brand new and it's unfolding. Like Amber said, it's anecdotal, but we are talking to our colleagues across the state and in different departments who are also noticing simply some populations not calling them back. And I can see where we're seen as an institution, sort of in alignment with other institutions that that populations do not trust. And so it's hard to provide care for people when their loved ones won't call us back. And we can't get a good idea of what their lived experience outside of the hospital is for discharge purposes. So we don't have data to support this yet. We have only our anecdotal experiences as well as that of our colleagues that are being shared with us. We're also facing some consolidation, so horizontal consolidation between the same types of organizations like hospitals, vertical consolidation across different types of entities like insurers acquiring pharmacy providers or hospitals acquiring physician practices, lab chains buying hospital labs, other systems kind of gobbling up smaller ones. So we have different kinds of entities. Today, entities that exist now but might not in the future. Tomorrow, those ones have ample resources and tend to be significant enough in size that they can easily purchase or financially dominate competing entities. And then those that are striving to maintain theirselves. And even in Oregon, we're looking at mergers of different hospital systems. And probably all of you who work in a hospital setting have seen different parts contracted out. And what does that mean when, say, your ICU staff work for a nationwide company and they're not accountable or educated in policy, maybe in the same way? Payment costs and coverage for pharmaceuticals. Some serious concerns about research and development on the horizon, and potential end cap on some medication costs. So, there was some significant work done previously to cap costs for patients for things like insulin, life-saving medications, and with discussions to roll back those protections. It will increase what Amber was saying before, people coming to us very critically ill, people who can't access these resources, then ending up in already overcrowded emergency rooms. And then these advancements in life sciences, all of these things have been talked about. mRNA research, gene therapy, Food and Drug Administration, National Institutes of Health, all of these things. There's been some new appointments to federal departments that are anomalous, not consistent with what we're used to for people who are appointed, causing a little anxiety about that. Policy and funding around life sciences, everything like regulatory, developing new tools, testing for efficacy, all of these things are losing funding and under tremendous strain. And so how are we going to provide care in a system that's already overloaded when we're potentially facing rollbacks in all of these areas as well?
So, to summarize so far, our patients' lives are up for grabs, and so are ours. And so the question then becomes, how do we hold that in ourselves? How do we hold each other? How, as healthcare leaders, do we hold the teams that we support? And I'm going to tell a couple personal stories here. One is that about 2 years ago, while managing the palliative care department, and I was new to that management, my life fell completely apart. I lost a work colleague to burnout. That person completely left the department, and that person was my 50%. They were carrying a great deal of what we carried together. And so I was left carrying it alone in crisis. My entire family came apart. I had to move out. I experienced stalking for the first time in my life. And I had to make a decision about how then to lead this team of people who were doing really complex end-of-life care work every day, in whom I had instilled values about authenticity and vulnerability. And here I was having experiences that to me felt like I should be able to manage and control them. I think it's safe to say, both recovering extreme type A personalities up here. And I had hyper managed everything in my life up until that point, and I was pretty sure I had it on lock. And then the whole thing came unglued. And I made the decision to be really radically vulnerable with the team I was leading. I shared with them what was happening in my life. Sometimes I asked them for help, and I tried to really manage the appropriate boundaries, but I also named where I was and what I needed. I told them when I had capacity and when I didn't. And it had a really powerful effect on the department. We are a very, very, very close team, and we take amazing care of each other. Recently, we interviewed someone, and after she left the interview, she texted me and said, well, I had to ask my colleague if that was real, because I haven't ever seen a team like that in healthcare before. And so I want to just take a moment here to advocate for the choice to be vulnerable. I think we are all in this room people who know how to tidy ourselves up, or we would not be here. And probably many of us also hyper managers of the things that we take care of. And when we do that and do that alone, and we don't bring our vulnerability to the table, we're leaving something behind that is absolutely essential in this kind of care environment. So the evidence tells us that being rigid and perfect and getting all the things right and putting a veneer over it is not effective in leading in a healthcare crisis. I did, in fact, Google how to lead in a healthcare crisis, how to lead in a personal crisis. And I found this lovely article, and it's really about the values that are most powerful here are holding, which is about naming and interpreting, and allowing for vulnerability, allowing the permission for ourselves and our colleagues to be vulnerable in situations that make us vulnerable, to not pretend otherwise. So a little more about what this looks like is, that we be curious and humble. And I want to name here that we're probably all really good at faux humility. I can act humble and then share with people just the right amount of managed vulnerability that it looks really charming. But there's a whole nother layer, right? That's not as pretty, it's not as cute, but it is transformational. And so I think when we talk about curiosity and humility, we have to go to that deeper level. And what the evidence says is that when you have these environments where people can safely be vulnerable, the error rates that get reported are higher, but the suspicion here is that it's because it's safe to say something went wrong. And anecdotally, I see this in the team that I manage, in that all day long, people can come to me and say, I don't know if I did that right, or this went really poorly for me today, or I'm struggling with this and I don't know what to do. And so that higher rate of reporting, I'm in struggle, I don't know if I know how to do this right, is actually a benefit. We want to see that on teams. And then in terms of this holding thing, that we want to be clear altogether about what's going on. What are we really facing? I think that's what we're all doing in this room today. And then therefore be able to learn improvisationally and iteratively with each other.
And this term vulnerability is complex for me. So it can be paternalistic and oppressive. It can serve to widen social control, and labeling groups as vulnerable can result in exclusion and stigmatization. And I was a person who used to chart something like vulnerable patient said this, or we need to protect this vulnerable patient. And until I read an article and it was brought to my attention, I hadn't considered what that might be like for a patient to be labeled vulnerable. Disempowerment might be a better term. Attention placed on deficits, dependency, passivity, rather than challenges, opportunities, autonomy, and self-determination. So problems of vulnerability reducing agendas, they aim to eliminate all of our vulnerability, suffering, any disability. And that was not my intent with using that word, but I could see how that might be read, how that might be felt. And I also committed to radical vulnerability. I think okay to name myself that. And I wanted to model it, and I'll share a failure as well. I was leading a group at the University District Hospital. I don't know if most of you know this, in Eugene, our hospital that was closed a couple years ago now. And I was on the team. We were in discernment about that, but it was obviously something that could not be widely disclosed. And I was working with my colleagues who I care deeply for, who worked there and were very committed to the work there. It was a large population of unhoused folks who we were caring for. And I felt this tremendous moral distress of carrying this secret. And then before one of the meetings, I got a call about a really devastating personal news. And I was crying, and I'm not a cute crier. It was like ugly cry, like snot, face was red. It was not good. And I was like, no, it's fine. This is fine. I can do it. And so I went and I led the meeting, and I was going through slides, and people were, kind of giving me the look, and I was like gaslighting them with my eyes, like, no, it's fine. Everything's fine. And I didn't say anything, and I just went through the whole meeting, not pretending, I guess. I don't know what that was. It was terrible. But I was thoughtful about it, and I thought, if I'm not going to model vulnerability, and then how is this going to show up in my colleagues? So weekly meeting, the next one, I went back and I apologized, not for crying, but because I pretended that everything was fine, and I forced them to participate in that really uncomfortable meeting where I could have just said, I can't do this today. And because I'm a professional and I didn't want to do that with 10 minutes notice, and I thought that would reflect poorly on me, I really just tried to push through. And so I asked for their compassion and understanding, and it was a diverse group of disciplines, and I got compassion and understanding from all of them.
So just to clarify again, what we're really distinguishing here is we can hold our own vulnerabilities. We can name those vulnerabilities and claim them and allow them to be centered in our lives as professionals. We want to be cautious about labeling other people as vulnerable, because often what we mean is this country has done bad things to them. And we don't want to fragilize people. And so we're really encouraging that when we focus our attention on vulnerability, we actually focus it on ourselves so that we can accompany well. I want to tell another story here. I swear this is all true. After my own personal unraveling came this year, and since January, on my team of 7 people, there have been 3 family deaths. One of them, in fact, just came a few days ago. 2 additional diagnoses of cancer, a really significant crisis around racism and fear of an unfounded deportation, and one of our caregivers was diagnosed with a terminal cancer and is continuing to work while undergoing treatment, sometimes with a 5FU pump on her hip. And we are not okay. And so there's this hall of mirrors going on in so many different ways. And I just think this is such a good encapsulation of this. Like, it's not like we ever don't bring our vulnerability to work, but sometimes it just turns neon, and that's what's happened for all of us. So we're doing end-of-life work in the hospital every day. We're coping with the fact that our beloved colleague will experience end of life, and she recently shared with us that she knows she won't be with us at this time next year. And we're watching her experience one emotional letting go after another. We're grieving the deaths of people in our families, many of them unexpected. And we're watching different people within our team try to navigate the healthcare system, as with Laura's parents. There was a day recently when I was listening to my colleague who has cancer on the phone trying to get a CT scan authorized for herself because it was delayed. She already had biopsy-proven cancer, and they just wanted a CT of chest, abdomen, pelvis. And she was on the phone in the middle of her workday and finally just said, I have cancer, on the phone with the insurance people. And I, having been a care manager for years, was like, give me the phone. It took 7 more phone calls. And it turned out the problem was, and this is a room of experts, and it still took weeks for her to get imaging, because the tertiary agency reviewing this decided that she didn't need pelvic imaging, just wasn't necessary. We later found out that she had diffuse adenopathy and bone mets. And that's just one example. And another person on our team experienced first having a close family member who was dying and no one in the family understanding what was happening except her. And so she was in this horrible crisis of trying to help them understand that their loved one was dying in real time and at risk of extreme suffering. And then she watched her loved one die in front of her, and I think it's the first time she had ever really seen that. And the next time she was in a patient's room who was actively dying, she experienced a really profound stress event that she had to then try to recover from. And so this is a particularly dense set of examples. For the record, we did schedule like a cleansing of our office yesterday.
It's getting saged right now.
But I do think that this kind of hall of mirrors suffering has been happening to all of us. And if we don't lovingly hold our all vulnerabilities in these spaces, then I think we're gonna just get sicker and sicker as human beings. And we need each other, we need ourselves, and we need, like, our families need us, and our patients need us.
I just want to go back a little bit to say, when we were thinking about this, when we were countering this, when we were noticing certain populations not seeming to want to be in conversation with us, more skepticism than we had previously encountered, we looked externally first. You know, I'm a philosopher, so I'm like, oh, there's a book for this. And I read lots of books, and I talked to lots of my smart friends, and it became clear that the answer was not going to be external. The rapid pace of change, a new executive order every day, is this one going to be implemented or not? How do we adapt to this? Is just causing so much chaos and so much distress, and things that we have previously felt were solid ground are not. And so it became clear to Amber and I that, like, the answer must be what we control. And I was so happy to see Viktor Frankl quoted this morning. That's one of my favorite. The two books I give everyone who graduates, Viktor Frankl's Man's Search for Meaning and Marcus Aurelius' Meditations. But I was so happy to see that, because I fully agree that our final freedom is internal. And so what I've been working on, and I think what we are working on, is how do we create a morally habitable space in all of this chaos? What does or what can it look like? It starts, this holding concept starts with courage, not bestowing safety on others from a place of authority. But Amber and I have found some traction in being radically vulnerable with our teams and inviting them to do that in whatever way feels comfortable. And again, not pretending like these problems aren't real and aren't big, but standing in solidarity with people.
So now we're going to tell you what that looks like for each of us.
So as she said, type A's. And we share podcasts all the time, and one we recently shared was about the importance of unstructured time. So I like to draw and sketch. I am not good at it. And 2 people on earth, until today, have seen my drawings or my sketches. And I have to work to not try and improve, to realize that the point of me drawing and sketching is not to produce a beautiful end result, but it's part of my self-care, it's part of unstructured time. And so in an act of extreme vulnerability, I am sharing some of my completed and half-completed drawings. I'm a birder, if you can't tell. I've entered that stage of my life.
And my version looks a little different. I've been doing end-of-life care in one way or another for about 12 years. Either partially or full-time. And I reached a point in my life where facing that much grief and loss, seeing that many people struggle against those final moments, it's not the peaceful deaths that are hard, right? It's the ones where people are terrified or believe it's not real, or don't know how to cope. it's just grueling. And having done that for all those years, I experienced progressively this internal demand for joy commensurate with the amount of grief I was holding. And I, by the grace of my sister, found something that feels just as powerfully exuberant, which is that every year I now dance in Carnival in San Francisco. So I cover myself in feathers and glitter and dance in the streets. Last time they counted, someone was wearing a pedometer, and we did 7 miles. We danced for 2 hours straight. It is celebratory and gigantic and bigger than life, and it is the light of my year.
And that is her adorable mother. I just want to point that out. And so part of our, one of the things I love about, I go to palliative care rounds every morning, and the first thing we do is, what color are you? Are you red? Are you orange? Are you yellow? Are you green? And then assignments are passed out based on where you are. If you're green, maybe you're taking more patients today. If you're saying I'm yellow or orange, we're gonna decide, she's gonna decide who gets what based on that. And the other commitment we've made is to subversive joy. And I'll just quote another one of my favorites, not an old author, but RuPaul Charles, or Mama Ru, who was being interviewed recently. I don't remember if it was Jimmy Kimmel, one of the late nights, and he said, anxiety and fear is the appropriate response for what's happening in the world. That is absolutely appropriate for what's happening. But we can also choose joy every day. We can choose subversive joy. And for my own piece that I heard recently was, if you're gonna throw a brick, you have to have your feet planted. So I think there will become a time when we are called to action in whatever way it is. And so I wanna make sure that my feet are planted firmly on the ground if I have the opportunity to be impactful beyond just the work I'm trying to do in my small section of the world. Thank you. We intentionally left this short because this is an adapting situation, and we've been hearing from our colleagues, but this is a captive audience of even more people across the state and in Washington. And so we're hopeful that you will share some of what you're encountering, if you're encountering any of these changes, and how your communities or teams might be dealing with it.
Yes. This is a three-quarters formed thought. And I feel like I need to spend time processing what you just said. Thank you so much for that. At the risk of stereotyping a little bit, it seems to me that what you're articulating is incredibly powerful, but also an explicitly feminine way of leading. And we work in a environment where 80% of us are women, and yet 3/4 of our leaders are men. Even if we leave national leaders out of this, I wonder how much you've experienced any kind of pushback. How do we invest more of what you are articulating in our organizations when that is so countercultural to the people who are actually leading them, despite feeling, I think, quite natural to so many of us in the room?
I appreciate that very much, Lori. I have encountered, I'll just speak for myself, some pushback of when we're seeing a trend or an issue, they want a policy. They want something teachable with bullet points, just like everyone wants ethics to be like an algorithm. You put some stuff in, some information comes out. It's not that. It's always time specific. So I have gotten that pushback. I know Amber can speak more intelligently about it, but hopefully it's okay to share her numbers in her department for like actual outcomes as well as employee satisfaction are the best in the hospital. They might be the best system. I don't know. I'll ask her to speak to that. But she's not putting policies in place. There's not a set of objectives. This is not a thing that can be printed out and handed to other people and duplicated. It's relational. And it required a lot of vulnerability on her part and inviting the rest of her team and I to be very vulnerable. And so I appreciate you calling that out, because I don't know that it's always appreciated in the way we might hope for.
Is this on? No. How do I make it go? Now is it on? It worked. So, okay, now I'm super fangirling because, yes, this is the subtext for me always. And I just want to take a moment to acknowledge Adrienne Marie Brown, Audre Lorde, Tricia Hersey, philosophers in our country who have really spoken to the ignored wisdom, the marginalized wisdom that is so essential to the healing of our country. And yeah, I agree. I've made really conscious choices to not move in the direction of structure and instead focus on radical loving presence and let that be the most transformative agent. I also want to just name a really particular human right now. I am incredibly privileged to have a director, Leslie Clements, who just powerfully embodies and supports this every single day of her life and her work. And I don't think everybody has that, but I do, my colleagues do, and that is a really powerful umbrella. And I'll just share briefly a story. I actually just kind of out of curiosity interviewed for another job, so I got a little peek outside her wing and was like, ugh! The interview process itself was so demoralizing. The questions that were asked of me just immediately showed me that the culture I live in is so particular and so precious and sacred. I will say that I think it's very, very hard to translate because there are so many people who have not grown their psychosocial, emotional, political vocabulary enough to even have a meaningful conversation. I think this goes back to the epistemic divide. Dr. Fair, where are you? It's a subtler version, but I think it's a huge one in leadership.
All right, just because no one else is talking. As someone that refers to your team, I just want to say the availability of the team, oftentimes, most days, they will come to us and say, we don't have capacity for any new patients today. And I don't feel like that's received anywhere in the hospital as like, they're never available. It's always, once they have time for this patient, they're going to put all of their effort into the patient. And so I appreciate that you do the red, green, yellow, whoever's available to put everything into this. Because if you were just numbers-based, just system-based, like you're saying, you wouldn't have that capacity to put into every case. So I appreciate your team.
Thank you so much for sharing that. I will take that back to the team. I think it will be really, really meaningful for them.
Thank you for bringing this subject to us. And if I'm hearing you right, you're talking about developing a culture. It's just not going to happen overnight, but it's by example. You're leading by example. But if I'm also hearing something that's underlying, it's developing the horizontal relationships. That we don't see any one role, any one person higher than the other. We treat the CEO the same way we do the janitor. We're all humans. And if I'm hearing you right, this is something that you're focusing on, and with that vulnerability, be able to communicate with all people on all levels. Is that correct?
That's exactly correct. Yes, thank you. Yeah. And like you said, it's hard because it doesn't happen overnight. It's showing up for each other all the time and built slowly over time. And so it's not the kind of fix that people want, like, oh, can we have a pizza party and everyone will feel better? And it's like, no, that's not going to work. We tried it. So it's much more complex and requires a lot of you, and it's relational, and so it's a lot messier. And I think working palliative care and ethics, you sort of have to get used to living where it's very, very messy. Yeah.
Thank you. My name is Fernando. I'm the manager of spiritual care at Legacy Salmon Creek. I want to build on Lori's question and your comments in relationship to her question about the style of relationship is very kind of feminine infused, and lots of leadership is sort of the opposite of that, perhaps. I've seen over the last, 10, 15 years, a movement in spiritual care that I'm not very fond of, which is to try to justify its existence by policy, to satisfy the hunger for data and graphs and reports, et cetera. And I find that somewhat lamentable. And because I think spiritual care at its essence is all the things you said. It's showing up, it's presence, it's relationship. And we have the luxury of time to do that with patients and families and staff. So it's a way of saying that at least in the spiritual care world, whether a particular department is dominated in numbers by men or women, I think the approach you mentioned so well is spiritual care showing up at its best.
Yeah, I appreciate that. Several people have talked about this. I can't remember all of it. Sorry, it's kind of a haze, kind of busy. But Eva Kate, lovely author, talks about feminist ethics and disability studies. And my favorite quote of hers is that the island of the man alone, it's a pernicious myth. So, so much of our structures and leadership models are sort of based on that, explicitly or not. And so what we're trying to model is the opposite of that. And like you said, it's taking time, it's listening. Like we began this, listening is one of the most powerful but also delicate forms of reaching out, not just waiting for someone to stop speaking, but actually listening to them. And it's hard work. I appreciate you sharing that. Our spiritual care colleagues are greatly appreciated.
I also want to share kind of a both-and perspective on this. My original education is with the Haas School of Business at UC Berkeley. My director is a LCSW of 20 years of palliative care experience who also has an MBA. And I think we both take pleasure in standing in the breach and interpreting between these two worlds. And so I do think there is a really important place. Claudia, you remember one time I talked about giving the bureaucracy its snacks? Like, if you feed it too much, it gets a little too monstrous. But we do have to be able to translate meaning in ways that help us talk to the C-suite, explain to a CFO why it makes sense to keep a particular department afloat. And so what I think that takes, in addition to this radical presence practice that we're talking about, is also people who enjoy that work. And I really do. And I think there are other people within healthcare who genuinely enjoy it. And so we just need enough of them in the right places so that we can have our weird, nerdy, interpretive party between human experience and data and financial value.
It almost seems in healthcare like that should actually be kind of a requirement for leadership.
I have a question. So thank you for sharing the modeling vulnerability piece. I wear 4 different hats in my professional work life. I'm the leader of an ethics program, and I teach internal medicine residents. I'm a primary care physician. I'm also a clinical ethicist. So as a leader, when I tried to model vulnerability, it was well received. It came out as humble and curious, creating space. But I am not sure how to do that in the other 3 roles, where I'm expected to behave like an expert, show, display confidence even when things are not certain. So how do you do that while also addressing the needs of what they are looking for in you?
That's an excellent question. I'm not a clinician, so I'll answer from the non-clinician and then hand it off. But I do tailor my talks. Like if I'm talking to nurses, because I sort of try and recognize what they put meaning and trust in, I will talk about trauma-informed care and epigenetics and how their unresolved trauma might be passed to their children, where they might not believe me and be motivated to provide care. They're very motivated if I say this will have intergenerational impacts on your children, unresolved moral distress. And so I guess it's not manipulative, but I'm definitely feeding the side of them that I know they put the most stock in, have the most value. And I try and build relationships from that, where they can go out on a limb a little bit more and see me as vulnerable in a way that doesn't undermine my authority. Because as working as an ethicist, you people wait for you to come in the room and you have to have an answer, right? And so it's definitely a fine line, and it depends on your audience. And yeah, they're looking for a certain type of expertise. And so that's my limited experience, and I'll turn it over to the clinician.
Yeah, okay. Just making sure this is working. So I have 2 stories about this. One feels good, one feels terrible. The feel-good story is that 2.5-ish years ago, I was working as the lead RN on the palliative care team and doing a lot of kind of preliminary internal work. And I read this thing that you can just make these tiny little adjustments in your life, like write down everything you love and everything you hate, and then just do like 10 more minutes of the thing you love. And what I figured out is that what I loved most was listening to my colleagues. And so I started just spending 10 more minutes every morning, having no agenda and just listening. And I felt really vulnerable because I was like, this isn't my job. And someone's gonna figure out that I'm like enjoying myself at work and I'm gonna get fired. And it was the best part of my morning every morning, and I was promoted instead. And I really think that it had to do with my presence, which is really what I was cultivating. And so I think it can feel like there's a push-pull there. I think there's a narrative that there is tension that maybe isn't as real as we perceive it to be if we step into that vulnerability from a place of love. That being said, the other day I approached a very, someone in the C-suite at our hospital from a place of vulnerability asking for greater accompaniment, and it did not go well. And that was painful. I experienced some cringy faces and what felt like a kind of a partial rejection of my value and my identity in that space. And so I want to be clear here that I do not propose that vulnerability goes well every time. It doesn't. But what was meaningful for me, even in that moment where I didn't have very much power at all, where it actually went somewhat poorly and felt a little bit hostile even, is that because I self-accompanied in that moment by choosing that, like, my tenderness, my need for partnership and companionship was meaningful enough to express, not from a place of defense or self-protection or righteousness, but from a place of genuine need and interest. I'm gonna take that into the next patient room I walk into, that internal integrity. And so I guess I wanna suggest that it's a project of our own integrity, even more so than it's a project of what outcomes result from our efforts.
Yeah, and I would also want to just ask you, because I'm just thinking in the moment, what would it look like for you to not meet their expectations? If they're expecting you to always know, which we know is a myth. I know you're a brilliant person with lots of titles who can't know everything, nobody does. But what would it mean for someone who has the reputation you do and all the education and credibility to redefine how you operate as a leader? So instead of other people doing it and what if you were the person who invited others to be an expert and be a leader in a different way? And I think that's what we have been trying to do, me on a much smaller scale than what you would be doing. But it is a little terrifying, but I have found, though it doesn't always go well, many people that you invite will want to join you there, because I'm thinking, if you're worrying about this, what are other clinicians with much less expertise, other people in the hierarchy, how do they feel about being vulnerable, and how powerful it might be for some of us to enter that space?
Thank you.
We have time for maybe 2 more questions.
I mean, you've got me going here on the vulnerability thing. I'm like, I mean, healthcare is so complex. I can't tell you how many times I have been, as a nurse, been a patient advocate, or, you know, talking about what patients need, or if I'm having a problem with a provider. And I mean, I have been written up, I can't tell you how many times. Like, vulnerability in this profession is like, it can be brutal. I have changed jobs over, you know, reporting poor practices of a doctor. Did I have anyone hold my, you know, like, retaliation? There's just so many buzzwords, diversity, equity, inclusion. That doesn't really happen. I mean, let's be honest. Those are just buzzwords. Trauma-informed care, buzzwords. Do I see this actually happening? No. Hell no. I mean, it's just a really, I can see, I mean, I'm part of a queer community. Do I ever take care of queer patients in hospice? Barely never, you know? And do I think that that community should be vulnerable? Not at all. Like, not now. I mean, especially not now, but I can't think of a time when it's been really okay. You know, I mean, if I've been a nurse like 12 years and I've taken care of like a handful of queer people in my 12 years, like, there's a problem. You know, and just me being a part of the system and being written up for being a patient advocate, reporting doctors that suck, and then it's all, I mean, I'm just so used to it being my problem. So yeah, vulnerability is like a huge, huge umbrella of, like, you know, I work in mainly rural communities now. Am I gonna be out as a clinician in those communities? Absolutely not. Absolutely not. Open carry weapons? Absolutely not. I mean, it's just a very complex question. I mean, I'm glad it's working for you, but oh my God, it's just, you know?
And I do want to recognize our privilege. Like, I have the privilege of being vulnerable for many reasons. So I appreciate you bringing that up, and I do want to recognize that I think those of us who feel like we're in safer spaces do have a higher moral obligation to start this work, because I do think it is a culture change, and I do have to hope it's possible, because I'm a hopeful person, but it will be incremental and slow, and I do feel like those of us that can do it safely should be modeling it, should be starting that.
I also want to express appreciation, because I think you've named the greater context that we didn't name, which is that this is about what to do with power. And when we are in situations where we aren't holding enough of it to be safe, it is not an act of social justice to be more vulnerable. And so where we are acutely vulnerable by our own experience, where we are targeted, to make ourselves more vulnerable is not, it's not the same thing. So I agree with you. I want to say something that is not, it's not a disagreement with you, it's a sort of a tangential point though that you brought up, which is we have a really complicated situation with doctors in our country, which is that there are people with problematic habits, behaviors, practices, and also we have a bunch of really, really vulnerable doctors in our country. Emotionally vulnerable. I said to my friend the other day, I was like, why doctors never call in sick? I was like, the only illness I can think of that I consistently see in the physicians I know is depression and suicidal ideation. Like, do you never get a cold? But it's true that for the most part, this is what I see happen to doctors, and it doesn't get talked about. And so there are any number of overlapping vulnerabilities, and certainly for someone who has significant, being a nurse in a world where doctors are privileged, being a queer person in a world where straight people are privileged, the obligations shift, I think, dramatically, for sure. And also, I want to just take a moment to acknowledge that there's like an iceberg of physician vulnerability also that we haven't really even begun to address as a nation.
Just a quick thought on vulnerability and leadership is that I think we can often synonymize whatever vulnerability maybe with weakness or incompetence when it's truly strength and transparency. And if our leadership is all about trust and relationship, then the ways that we figure out to be vulnerable and to open ourselves up that way will build more trust and relationship. And I think the model of what you guys are doing is beautiful. And so I just wanted to highlight that.
Thank you, we appreciate that. I think that's the end of our time if there are no more questions. We appreciate you taking the time to listen to our project.